Welcome to Impactful Chats. I'm Malin Martinez,
And hi, I'm Seth Kruger.
and we're here today with Dr. Will Parker. Thanks for joining us, Will.
Uh, Good to be with you.
Yeah, and so we have Will here today to talk about the ethics of vaccine distribution. He recently had an op-ed published in the Chicago Tribune about basically just explaining to Mayor Lori Lightfoot, the mayor of Chicago, why perhaps our vaccine distribution process might not have been the ethical strategy. So do you want to start by just kind of telling people a little bit about that?
Yeah, sure. It was more calling out that the prioritization phases for vaccine distribution can be allowed to be overlapping. So, what prioritization is about directing vaccine to vulnerable populations that need it the most. It's not supposed to be this rigid gatekeeping mechanism where, somebody doesn't meet the eligibility criteria, and if you give them a vaccine, it's a crime, which I think Cuomo was playing around with in New York, and it is a bad idea. It's really about, from a public health perspective, what are the populations that ideally we should be focusing on. They were never intended to slow the rate of vaccination in the city. Making sure that you rigidly get through every single person in a phase before you move to the next one was never supported by any of the framers of these frameworks.
Yeah, so speaking of frameworks, I think two of the most discussed frameworks are the National Academy of Medicine and the CDC's foundational or ethical procedural principles. Can you talk about those and the differences there?
Yeah, there actually are material differences between the National Academy of Medicine and the CDC's framework. They both espouse two of the same three principles. One is maximizing benefits, just sort of save the most lives, return society to normal functioning. So there's kind of subgroups of that from that principle. The next one is mitigate health inequities. Both the National Academy of Medicine and the CDC agree on that. But the third principle is actually different. The National Academy of Medicine talks about equal concern for every person. That would be sort of the idea that everyone should have access to the vaccine. At some point, everyone's a human being, right? Whereas the CDC talks about promoting justice, sort of a more complicated topic, which might justify you prioritizing somebody with a higher risk of death from COVID mortality, for example. So you're trying to give everyone an equal chance of having the same health outcome. The National Academy of Medicine also talks explicitly about equity being a cross-cutting consideration throughout all phases. That's derived more from the mitigating health inequities principle. So there are some fundamental ethical principle differences between the two frameworks, and then their practical protocols that they derive from these frameworks also differ significantly.
Right.
Um,
I think actually it's important to pause for just a second and explain to the viewers why you're a voice we should be listening to in this area. Can you describe your area
that,
of expertise here?
yeah, that's a good question. I actually study organ allocation as my day job. I'm interested in the allocation of scarce resources in general. I'm an intensive care unit doctor. So COVID was something that I got drawn into because of my clinical exposure to taking care of many patients with the disease and my interest in the ethical, the ethics of allocating scarce medical resources. So didn't know much about vaccines before this year, and had been learning as much as I can. But I do have expertise in the underlying ethical principles that form these prioritization phases that we've all heard so much about.
Right, and you're also involved in at University of Chicago, one of our ethics programs. Is that correct?
Yeah, I'm an assistant director for the McLean Center of Clinical Medical Ethics,
Right.
as well as assistant professor of medicine in the section of pulmonary critical care.
Okay.
Yeah, and I think that all makes sense. I mean, a year ago, very few of us who were practicing pandemic medicine had any expertise in pandemics per se, and we're now kind of all pandemic docs to some extent. So that's what we do now.
Yeah, the organ allocation is an area where there's a chronic scarcity, right? There's always way more patients who need organs than there's available supply. So in some ways, it is a literature that has developed these ethical frameworks and practical protocols for distributing these scarce resources, because it's like a chronic problem for organs, right? And so it was a good foundation to start from. And it was interesting seeing the differences in the way these some of these frameworks got brought to prime time.
Right. And then you were talking about the differences between the CDC and the NAM ethical and procedural principles, but can you also talk about the technical differences between how they formatted their rollout phases and who's included in each of the phases?
Yeah, so NAM acknowledged, just called the phases 1, 2, 3, 4 instead of getting all the sub levels of CDC's 1A, 1B, and 1C, right? So that's an important difference. And so the NAM phase 1 involved a jumpstart phase with healthcare workers, so that much agrees that they called phase 1AB. But then it was sort of, and first responders, they included in that group too. So like a subset of frontline essential workers who were doing directly providing pandemic care, NAM included them in phase 1. And then it was all adults at high risk of death from COVID, at very high risk of death from COVID would be in phase 1, broadly defined, right? They didn't really specify how, because this was over the summer. They assumed we'd have more information about how we'd be able to identify those people. And then phase 2 was the essential workers and other adults at kind of moderately high risk of COVID. Now, in contrast to the CDC, which narrowly defined phase 1A as healthcare workers and residents of long-term care facilities like nursing homes. So that did not include this broader population of adults at high risk of death from COVID. Hence, I believe making phase 1A too narrow. And that was why part of the reason the rollout was so slow. Not the whole reason, obviously, but I think that was when we look back and we're Monday morning quarterback the rollout, I think of recognizing that 1A was sort of a convenience group that the CDC picked out of 20 million people for 20 million doses. Remember, we were supposed to do 20 million doses by the end of December. They just thought that, okay, then now we sort of have the right number of doses available for this group, and didn't really think about the fact that a lot of healthcare workers have had COVID, so they're not going to get the shot, right? They shouldn't in 90 days. And if you had it 4 months ago, you still might have immunity. So some people might not want to get it so someone else can get it instead, right? And then the other thing is hesitancy has been much higher than expected. And so they were sort of assuming 100% uptake in this very broad population of healthcare workers, which by the way includes not just frontline people actually taking care of COVID patients or patients in person, but that 20 million number includes administrators and people who are in no way patient facing, where we've had some press about why is this non-patient facing administrator getting a vaccine before my 90-year-old grandma? Well, that comes right out of the CDC's framework. That's not the hospital's fault. That was included in that 20 million number. So obviously, I don't think that the framework was perfect, and I don't think first of all, I don't think there is a perfect framework. I'll say that as well. But one of the other errors was once vaccine acceptance started to slow down, phase 1B should have been activated and overlapped at a couple weeks earlier than it actually went down.
Well, why is that?
Why is that? It's basically because people were looking at the percentage of the total healthcare worker population that was vaccinated and frustrated that it wasn't high enough. I think that was part of it. And wanting that the percentage of healthcare workers who had, received a vaccine to go up before activating the next phase. But that's actually probably not the right metric to be, focusing on. So this is something I'm sort of thinking about for 1C, right? What's the threshold going to be to activate 1C? And we're gonna have the same problem. And hopefully we had better, more enlightened metrics in recognizing that overlap is not unethical. In fact, it's the ethical thing to do, right? It's the way to make the best use of a scarce resource. You got to use it, and you shouldn't let these rigid distinctions between priority groups, which by the way aren't ethical consensus anyway. That's why we had that whole long conversation about the different priority groups. There's a lot of debate about who should be in which of these groups. So acknowledging that these groups are imperfect, once you start to see demand slow down within a group, activate the next one and let them overlap.
Got it.
Yeah. So within waves, how are we going to, further prioritize who's next prioritized? There's so, like you said, there's really complicated. There's numbers and letters and tiers and sub-tiers and phases. How are we deciding who's next and who should be next?
I think at a certain point, you won't be able to make lexical rank orderings of every person in the US, right? So you should just do a lottery. That's what we're doing at University of Chicago. So everyone who meets the current phase 1B criteria CDPH is allowing us to distribute our access doses to. We're starting with people over 75 who live on the south side. There's a lot of those people, and we're just running a lottery. And then whoever wins the lottery gets the opportunity to sign up for an appointment. Fortunately, we're able to move quickly through that subpopulation and then expanding down to 65 after that. So there is probably some room for sub-prioritization by age or chronic conditions within 1B. But at the end of the day, you're going to have a bunch of people who are eligible. Too many, hopefully, demand should exceed supply all the time. We should be activating enough phases so we have more demand than supply. And well, how are you going to sort that out when you have people sort of equal need for the vaccine? You need to do it randomly. First come, first serve is unacceptable from an ethical perspective. I mean, all these, I don't understand why, even if you have to sign people up, let's say you don't have a database to auto enroll people from. Fine, I understand that the health infrastructure in this country is terrible, but you let people sign up, over a course of a week before you roll out the next phase, and then you just start randomly assigning appointments. It's like you can do it in Excel and take you 1 minute, but instead they're making seniors wait in physical lines. I mean, it's just insane. So anyway, I had to get my rant in about why first come first serve is bad, because that's the one thing where it seems to be the rule, not the exception, but it has no ethical justification.
Right, and I mean, and that's exactly your perspective that we were interested in hearing about. So, so I'm glad you shared that with us. And also, what about the sort of doses that have gone wasted and deferring of second doses? What are your thoughts on that?
I don't think many doses have actually been physically wasted, in the sense that they expire and cannot be injected into anyone. I mean, Dr. Arwadi in Chicago, for example, said today we've had zero wastage. I don't know if that's true, but that's, basically close to zero. I think so separating wasting of raw doses versus it being unacceptable that doses are sitting idle in the freezer. Being idle in the freezer is bad, wasting is worse. So I think the wasting problem is not as nearly as significant as the doses sitting idle in terms of total numbers.
Yeah, so there's been a lot of discussion of deferring second doses, either just giving everyone a first dose until weeks or months from now when we have a second dose, because there's some evidence that one dose provides some immunity, or spreading out when people get their second dose. Can you talk about that a bit?
Yeah, so that comes from, if you looked at the Kaplan-Meier plot from the clinical trial, you sort of, I'm going to draw with my finger, constant in the placebo arm, the risk just goes up, 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 right? In the vaccine arm, it mirrors the placebo arm for about 7 to 10 days, and then just takes a right-hand turn, and almost no one gets infected again. So it seems like the first dose, from just a pure survival analysis, time to event analysis perspective, establishes immunity, lowers the hazard of actually getting infected. The problem is we have no idea what would happen without the second dose, right? Maybe the immunity wears off, and your you would only be immune for a couple of weeks. But the idea of a deferred dose is, we're not saying don't get the second dose. We're saying we're going to give you the second dose when supply becomes sufficient, it becomes available. So if people end up waiting, instead of 4 weeks for Moderna, they end up getting it at 8 weeks, maybe that'll be good enough. And so that's the theory. The problem is from a data perspective, we haven't observed the counterfactual where somebody doesn't get their second dose. I mean, we actually will, because people are just going to not take their second dose. So I think there's a role for really careful causal analysis, empirical studies to identify people who are not taking their second dose, make sure that there's not confounding, and see how they do.
Yeah. Well, what are your thoughts on how logistics and ethics and science sort of collided in some of the vaccine rollout snafus, like at Stanford or Harvard?
Yeah, I think the Stanford story is one where they thought very carefully about the principles that they wanted involved in their allocation score. They're actually pretty reasonable. Age is one of the biggest risk factors for dying from COVID-19, the single biggest risk factor in multivariable regressions, right? And so you want to weight that highly, fine. And then the other thing that they included in their score was how many people got infected in your area of work. So, that was supposed to be very egalitarian, it didn't prioritize food service workers hires, for example. But it turned out, when they applied it to data, they didn't have anything to put in for residents, like where they were actually working, right? So they got kind of a 0 for that part of the score. And all the residents are, in their late 20s, early 30s. So they got very low scores that way. And we're only 7 out of 5,000 were supposed to get allocated in their first wave of vaccination. And, that actually isn't necessarily unethical from at face value, right? I mean, there's an argument to be made whether that's acceptable or not. The residents certainly felt like reciprocity or payback for services rendered guaranteed them a spot. There's also an instrumental value argument. So that's the multiplier effect, is residents are sort of key to the hospital functioning, right? So you want to protect them to keep them in the workforce so the hospital goes forward and continues to function well. That's not in their score. So there are ethical criticisms of the Stanford score itself, but I think the biggest problem was that they just developed it in secret, didn't bring the residents to the table, didn't publish their rank ordering at all, even though they had actually applied it to data several days before, and make it transparent. And so, if they had done those things, they probably would have realized, well, this isn't going to work, to not vaccinate any of the residents. This is going to be a disaster, and probably fixed it ahead of time. Or maybe they would have made a really compelling argument and the residents would have understood and not been so upset. So I think the moral of that story is that transparency is key, and it's one of the key pre-process values, ethical principles in both the NAM framework, National Academy of Medicine framework, and the CDC framework. It's like step one: you be transparent, put it on the internet, and that's what we're trying to do at UFC, and try to be really send out tons of emails, be like, this is exactly what we're doing. Here's what, and not everybody's gonna be happy with it, but that's sort of it's not sufficient, but a necessary condition for something to be ethical.
Right.
Yeah, so you mentioned a lot of decision makers here. There's the NAM and CDC general principles. There's our local Department of Health, which is allowing the hospital to make decisions. There's hospital administrators who are deciding things. Who is deciding all this? Like, how many people decide? Like, I got my doses. Who needed to say yes? I deserve my doses. These people don't. Like, who's making all of these decisions?
Well, lots getting kicked down the can, the can's getting kicked down.
Yeah.
Right? Is sort of, maybe things will change tomorrow. We're filming this January 19th. So on January 20th, maybe things will start to change where there'll be more leadership from the federal government going forward, and more, what I think it's fine to delegate things to local leaders or even institutions, because they know their patient populations the best, right? They can most deliver. You don't want to micromanage, right? Micromanagement's bad, but not having performance standards is also bad. Like, not saying we expect 90% of your allocated doses to be in somebody's arm in a week, and figure that out. That's sort of the leadership we need at this point. And I think that's hopefully most institutions who are receiving shipments should have that mentality that, it's time to get needles in arms. There's, you identify through an equitable manner a high risk, high vulnerable population. There should be enough of those patients that you can do that, and do it fairly, reaching out to the communities who are at greatest risk, particularly on the South and West side. Those people are there that want the vaccine right now. So, I mean, it can be done. And, I think just setting those standards of performance is what's really needed in this next phase.
Yeah, I will add in, I think pushing it downhill without resources or the information to do it was a big part of it as well. Public health is chronically underfunded well before COVID. Then testing and lots of other stuff was pushed on state and local health departments. And now another big lift was put on them. It was a setup for failure. And I don't think that was all necessarily an accident as far as an abdication of responsibility from the Trump administration.
Yeah, no, I think that's clear. It was a clear failure that started from the top. And, everyone at these local Department of Public Health wants to do the best, they can with their resources, and are working very, very hard. So I certainly acknowledge that. But hopefully we can just sort of kick it into overdrive going forward.
Really. Well, Will, thank you so much for joining us to talk about this. I think there's a lot of emotions surrounding this vaccine rollout, and I think people feel a lot of people might feel left out of where they are in the vaccine rollout, not understand how and why things are being prioritized the way they are. So I think it really helps to have someone like you, an ethicist here, kind of describing what makes sense and why decisions are being made the way they are. So thank you for joining us.
No problem. Yeah, I mean, this is there's not ethical consensus on a lot of this stuff. These are really tough choices, and anytime you don't have enough of a medical therapy that somebody needs, it's a tragedy. And that's what's going on right now. The pandemic is a tragedy, and it's a tragedy we don't have enough vaccine for everyone right now too. So that's I just I hope that it's as short-lived as it possibly can be.
Exactly. All right. Well, thanks for joining us.
Great.
Thank
Thanks.
you.
Stay safe.